Assalamu alaikum, everybody. Okay, I'm sorry I was late. There was some connection error. Anyway, so we are going to discuss basically a new topic, which is again an inflammatory disorder of the muscles and skin that is going to affect your proximal muscles, and especially the shoulder girdle and the limb girdle muscles, leading to chronic inflammatory disease, leading to weakness, with the constitutive symptoms of fever, aches and pains, arthritis, and at the same time, multisystemic involvement involving your joints, your lungs, heart, as we discussed in scleroderma and other connective tissue disorders. So it is one of the series of connective tissue disorders leading to involvement of the muscle, skin, and your system, including your heart, your lungs, and the other rest of the body. So polymyositis is again a subacute or slowly progressive symmetrical weakness, primarily affecting the proximal limbs and the trunk muscles. So you have body pains, especially involving the shoulder girdle and the limb girdle, the muscles of the buttock, and your thigh muscles. Basically, there is proximal myopathy, chronic inflammation leading to weakness and atrophy of the muscles. So it is one of the chronic inflammatory disorder involving the muscles. Polymyositis can be differentiated into a chronic inflammatory disorder, which is a primary polymyositis, and if polymyositis is associated with a skin manifestation like Gauthron papules, periorbital heliotrope rash, and other skin involvement, that is called dermatomyositis. Means polymyositis with a skin involvement, that is dermatomyositis. Sometimes there is a dermatomyositis, polymyositis associated with underlying malignancy. So it can be a paraneoplastic syndrome involving muscles and the skin. And polymyositis, dermatomyositis associated with connective tissue disorders, especially SLE and other inflammatory connective tissue disorder, that is your collagenopathies. We see the other variety, which is including body myositis, which is very rare, and amyopathic dermatomyositis, which is a muscle atrophy and leading to skin involvement. So we will discuss today the polymyositis and dermatomyositis. The polymyositis is a chronic inflammation of the muscles involving your limb girdle, especially the shoulder muscles and the your hip muscles. And dermatomyositis is a skin manifestation associated with polymyositis. So polymyositis, basically it is a one of the rare disease, 2 in 10 cases 1 million, and usually age of onset is 45 to 50 in 5th to 4th decade, but can be seen in young adults, even in children who have underlying paraneoplastic disorder. And female are more commonly affected than males, as we know rheumatoid arthritis or uh, uh, scleroderma, SLE. These are all connective tissue disorders, are more common in females as compared to males. And blacks are more commonly affected as compared to whites. Okay, if we look at the clinical manifestations of polymyositis, because it is a chronic inflammatory disease of the muscles that lead to swelling and leading to weakness and atrophy of the muscles. The muscles of the shoulder girdle, pelvic girdle, and neck flexors are commonly involved, and patient may have difficulty in raising the arms, uh, difficulty in standing from a supportive position, and patient sits on the chair and unable to stand up, or even in the washroom they sit on the commodes and unable to stand up because of the pelvic girdle muscle involvement, and there may be a neck flexors. Patient may have weakness of the neck flexors. And myalgia pains are not that bad, but it is a syndrome of polymyositis that can be associated with a low-grade fever, with the fatigue, with the weakness and weight loss. So constitutional symptoms may be there, but usually there is a gradual weakness and wasting of the muscles of the limb girdle. It can be a manifestation, or it can present in different ways, like muscle pains with weakness and difficulty in sitting, uh, in standing from sitting position, like limb girdle muscle involvement. Apart from muscle inflammatory disease, it can be a part of arthritic. Patient may have arthralgia or arthritis in 20 to 70% of patients, and patient may have pulmonary involvement leading to interstitial lung disease or interstitial pulmonary fibrosis in 10% of patients. Gastrointestinal motility, as we discussed in scleroderma, they usually have difficulty in swallowing due to esophageal motility disorders and involving the intestine, leading to malabsorption, and large gut may have wide mouth divertical disease. But here, esophageal motility disorder is seen in 10 to 30% of patients. Cardiac involvement, again, you can have conduction defects. They may have some heart blocks or may have arrhythmia because of the cardiac involvement. And vasculopathy, especially Raynaud's phenomena, is seen in 20 to 40% patients. So patient may have Raynaud's phenomena present to you with pain in hands, and they have blue and red discoloration after exposure to cold, and they better gets better when they re-warm or keep the hands warm, especially in cold weather. So we have already discussed in scleroderma and crest syndrome, that may be a manifestation. So same is Raynaud's phenomena can be seen in patient with polymyositis. Skin rash like livedo reticularis are common in polymyositis, but dermatomyositis have more dermatological manifestation rather than with top of polymyositis. Only polymyositis skin manifestations, only livedo reticularis is really seen. Okay, so what is the prognosis? If patient is having polymyositis, and usually they have a 5-year survival around 85% in polymyositis, means it's a disease which is a gradually worsening disease leading to shoulder girdle and the hip girdle muscles. It may be associated with dermatomyositis or polymyositis with associated dermatomyositic connective tissue disorder, or sometimes overlap syndrome. Means you have scleroderma, SLE, polymyositis, dermatomyositis. These are all connective tissue disorders. It is a much lower in combination polymyositis and dermatomyositis. One of the major manifestation of underlying malignancy may be a presentation of dermatomyositis. So dermatomyositis is usually associated with underlying malignancy, especially patients who are elderly. So if you look at the polymyositis, as I told you, it is a chronic persistent inflammatory disease of the muscles that causes weakness, and muscles are gets the patient gets easy fatigability, weakness, and lethargic. And if we look at the polymyositis, it can be classified in chronic inflammatory myopathy, and one of the three diseases which are seen in polymyositis, that is, it can occur at any age. Adults, usually 30 to 50 years, are more commonly affected. Blacks are more commonly affected, and female are more affected than males, 4:1 ratio. So polymyositis may present with the symptoms and signs usually develop gradually over weeks and months, and patients usually have muscle weakness, especially the shoulder muscle. He may have difficulty in driving or may have difficulty raising their arms, and because of the muscle inflammation and wasting and later on weakness. And remissions are usually rare because it is a chronic disease, and the gradual inflammation of the muscles leading to weakness and wasting. And remission can be achieved by therapies like steroids or immune modulating drugs. But these are the patients who don't have spontaneous remission. That is, spontaneous recovery is rare in these patients because if we look at the SLE and other diseases, they can have a spontaneous remission. But here you have a disease process which is a chronic disorder leading to weakness and wasting of the muscles. Patient may present with progressive muscle weakness and the difficulty in swallowing involving the esophageal muscles. They have dysphagia, difficulty in swallowing, may have may have difficulty in speech because of the involvement of the muscles of the face, and the mild may have arthritic changes, may have arthralgia or arthritis. Fatigability is very common because patients have chronic inflammation of the muscles leading to weakness and fatigability, especially the limb girdle muscles, and may have pulmonary involvement leading to interstitial fibrosis and interstitial lung disease leading to pulmonary fibrosis, and may have shortness of breath, especially initially it may be on exertion, and then patient may become dyspneic at rest and even on oxygen dependent. And other manifestation, especially the trunk muscles, which are particularly the muscles which are commonly affected, are the hip muscles, thighs, shoulders, upper arms, and the neck. Especially neck flexors are more commonly affected than extensors. So it is going to have a proximal myopathy, and usually it is a symmetrical muscular weakness and inflammation, and worse because it is a gradual worsening disease, chronic inflammatory disease with no spontaneous remissions. It is a worsening disease and lead to wasting and the weakness of the muscle. So as muscle weakness progresses, patient usually have difficulty in climbing stairs, rising from the seated position. And patient, I told you, patient may go to washroom and sitting on the commode and unable to stand up because of the limb girdle and hip muscle weakness. So lifting the objects or reach the overhead may be difficult. So the combing, patient may have difficulty combing their hair, or may have difficulty in driving, especially involving the shoulder muscles. So all limb girdle muscles, especially shoulder and the hips, are gradually weak and wasted, and patient may have difficulty in their routine activities. Complication, I told you, may have esophageal involvement leading to motility disorder with dysphagia, and which may lead to poor intake and weight loss and malnutrition. So one of the manifestation may have, patient may comes to you with a history of dysphagia, poor intake, he is wasted, emaciated, and there is a gradual weight loss and malnutrition. Because of the involvement of the respiratory muscles, these are the patients who can have aspiration pneumonias, and patient may present because of poor dysphagia, and patient may have regurgitation and leading to aspiration pneumonias. Shortness of breath is usually because of pulmonary fibrosis and interstitial lung disease, leading to shortness of breath, and patient may lead to hypoxemia and sometimes worsening to respiratory failure, and may die because of the chronic hypoxemia and respiratory failure. Calcinosis is just like in scleroderma, they may have calcinosis. They are the calcium deposits in muscle, skin, and the connective tissues. So, polymyositis may have complication involving the motility disorder, causing dysphagia and leading to malabsorption and weight loss and malnutrition. And aspiration pneumonias may have, because of dysphagia, have aspiration, reflux of nutrients and leading to aspiration pneumonias. And shortness of breath because of respiratory failure, calcinosis, and at the same time, they may have cardiac involvement leading to heart blocks and heart failure. Okay, polymyositis may be associated with other conditions that may cause further complication of their own. Like polymyositis may have Raynaud's phenomenon. As told you, patient with polymyositis may have other manifestation of collagenopathies, and there may be a overlap syndrome, polymyositis with the dermatomyositis, polymyositis with the scleroderma, polymyositis with the SLE, polymyositis with mixed connective tissue disorders. So these are the some overlap syndrome, and patient may present with Raynaud's phenomenon. That is, your hands become painful, they become white, blue, and red, and the treatment is calcium channel blockers, and avoid the exposure to cold, and even heated gloves can be used. Other connective tissue diseases, like I told you, can have associated overlap syndrome like scleroderma, like SLE, like other collagenopathies. Cardiovascular diseases, these are the patients who have associated cardiac manifestations. They may have heart blocks and other manifestations, and lung diseases, usually leading to interstitial pulmonary fibrosis. Okay, so patient with the history of progressive muscle weakness and unable to drive, unable to comb, and difficulty raising the arms, or he says he has difficulty in standing from a sitting position, or he goes to washroom, and once he is on the commode, and after defecation, he is unable to stand because of the hip muscles and limb girdle muscles are weak. So patient usually they will have weakness that is symmetrical proximal muscle weakness. So one of the diagnostic criteria is proximal muscle weakness, especially the limb girdle and the shoulder girdle and the hip girdle. And patient, if you check their CPK level, that is because of the inflammation and myocyte damage, they will have high CPK, aldolase, myoglobin, AST, ALT, and LDH level will be great, especially CPK, which is a more specific, and aldolase. Sometimes these are the patients who have severe muscle damage, even leading to muscle renal involvement and leading to renal disease, renal failure. So other diagnostic criteria, electrodiagnostic, that is if you go for electromyography and nerve conduction study. Electromyography, patient with polymyositis and dermatomyositis will have polyphasic action potentials, short duration and low amplitude. And while their nerve conduction studies would be normal. If you go their neuropathic disorders, these are the patients who have polyphasic action potential, long slend duration, and large amplitude, and nerve conduction velocity is abnormal. So polymyositis dermatomyositis, if you do the muscle biopsy, and they will have histological evidence of inflammation. I told you later on, and if you check their tests like electromyography and nerve conduction study, electromyography is going to show polyphasic action potentials with short duration and low amplitude because of the muscles are wasted, inflamed, and leading to low amplitude action potentials. And nerve conduction study would be normal. If we go for the muscle biopsy, that you want to check the inflammatory disease of the muscles, especially if we go for MRI and other modality can be used. So they muscle biopsy will reveal perivascular and endomyosial inflammation. There's CD8, CD T cells in polymyositis, and CD8 and CD4 T and B cells in dermatomyositis. So there is an inflammation of the CD8 cells, CD8 T cells in polymyositis, and CD8, CD4 T B cells in dermatomyositis. So muscle histology will show highly perivascular endomyosial inflammation with infiltration of the CD8 and CD in patient with polymyositis and dermatomyositis. Muscle fibrosis, necrosis, and regeneration would also be visible on histological slide. As we told you, we have asked for the muscle inflammation and progressive damage of the muscle that will be reflected by high muscle enzyme, especially CPK. CPK, aldolase, all muscle enzymes are raised. And acute inflammatory response may be reflected by high ESR, CRP, and ANA is positive in 50 to 80% of patients. If we go for autoantibodies, that is anti-ribonuclear antibody, which is seen in misconduction disease, and uh, polymyositis scleroderma overlap syndrome, that is they are anti-RNP and anti-SCL. In scleroderma, we ask for SCL 70. But in polymyositis, there may be an overlap syndrome, scleroderma with polymyositis, and there may be anti-PMC SCL. While misconduction disease, there will be anti-RNP. So more specific autoantibodies which are seen in patients with polymyositis is anti-Jo, anti-SRP, and anti-MI2 antibodies. So these are the anti-Jo, one part of the anti-synthetase antibody, antibody to antigen endomysial RNA synthesis, synthetase. So these are seen in patients with the polymyositis in 20 to 50% of patients, and it is more common in patients with polymyositis and less common in patients with dermatomyositis. Anti-SRP, anti-signal recognition particles in 5% patient with polymyositis, and anti-MI2 in 10% patient. Sorry, in anti-Jo antibody, which are antibody to antigen endomycin antibody synthetase, they are seen in polymyositis and more in dermatomyositis. Okay, so what are the options? So patient has come to you with history of progressive muscle wasting, weakness, and he is unable to lift his arms. Combing is difficult, unable to stand from a sitting position, and you have seen his CPK levels are high, and ESR is raised, CRP are raised, and you go for electromyography that showed short duration action potential, and you go for muscle biopsy, and they show inflammatory muscle involvement with its your T cell in CD4 and CD8 cells, and you make a diagnosis of polymyositis. And what are the options? Because it is an inflammatory disease, and sometimes it is an autoimmune related disorder. So you go for anti-inflammatory drugs and immunosuppressive agents. So anti-inflammatory drugs, very common. Steroids are used as anti-inflammatory, and immunosuppression as immune modulating drugs like methotrexate, azathioprine, cytoxan, and calcium can be used. While immune modulating drugs, you can give IVIG immunoglobulin or even sometimes plasmapheresis. Patients who are in polymyositis with severe weakness and in crisis, they can go for plasmapheresis. And sure, these are the patients who have chronic inflammatory disease. They need rehabilitation and some uh, 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 your social economic support. So this is the basically concept why this chronic inflammatory disorder takes place. And if you look at the interleukin 1, interleukin 10, and the tumor necrosis factor. So tumor necrosis factor, interleukin B and D are the pro-inflammatory cells. Pro-inflammatory, they are high in number, and that leads to severe inflammation of the muscles, and these are the inflammatory process. Tumor necrosis factor alpha and anti-inflammatory, if you go for in interleukin, and these are the inflammatory process that takes to inflammation of the muscles. If we look at the macrophage activation and T cell activation, and this is the human necrosis factor receptors, and if you look at the tumor necrosis factor that attaches with the target cells and lead to chronic inflammation. There's another view of inflammatory cytokines. They attach to the cytokine receptors, leading to inflammation of the muscles. And monoclonal antibody, soluble receptor, and there is no signals. If we look at the activation of the receptor at anti-inflammatory pathway, these are the you use the drugs which act as inflammatory receptors, and they lead to anti-inflammatory cytokine and suppression of the inflammatory cytokine. So here you look at the inflammatory process, cytokine receptors, inflammatory cytokine, they attach here, leading to inflammation. And if you dislodge or clear these receptors, and your inflammation can be stopped by anti-inflammatory drugs. Other drugs which are used as a human antibody, these are the drugs which can be used as antibody and let the patient to have a free of the antibody, means you can have the plasmapheresis. Anti-inflammatory drugs commonly used in maximum number of patients, and cheaper drugs, but can lead to complication like chronic steroids can lead to Cushing syndrome, hypertension, diabetes mellitus. But you need to reduce the dose of steroid as the disease process is patient go into remission, and his ESR has settled down, his CRP has settled down, and he is symptomatically better. So muscle strength improves after 4 to 6 months. He can walk, steroid therapy and these are the drugs which are gradually tapered off over 6 to 8 weeks. Small dose of steroid like 5 to 7.5 milligram can be used per day because if you increase the dose more than 10 milligram, more than 7.5 to 10, that but you cut down or maintain at 5 milligrams per milligram per day. Okay, what are the options we have? I told you intravenous immunoglobulin can be given is a purified blood product that contain healthy antibodies from the thousands of blood donors, and IVIG immunoglobulin can be a remedy for patients who are in polymyositic crisis. So healthy antibodies, IVIG can block the damaging antibodies that attack the muscle in polymyositis, and repeat infusion can be taken over 6 to 8 weeks. Other anti-inflammatory drugs, immunosuppressants can be used like tacrolimus or cyclophosphamide cytokines. And rituximab is a new drugs and tumor necrosis factor and inhibitors in tumor necrosis factor antagonists are although used as a biological therapies to go for remission. So this is a chronic illness as polymyositis leading to lymphoedema involvement, leading to weakness and wasting, and may have other constitutional symptoms like fever, myalgias, arthralgias, and involvement of the esophagus, in the involvement of the lungs, involvement of the heart, and other part of the body, especially skin, not skin, so especially the Raynaud's phenomena. So nursing care of these patients is very, very important because they are given psychosocial and support because it is a chronic disease usually leading to muscle wasting, and patient has a difficulty in coping, and patients especially on long-term steroids can have other complications, especially they can have osteopenia and Cushing syndrome, diabetes mellitus, hypertension, and these are the clinical manifestations. So counseling of the patient is very important, coping and sport, and educate about the illness and balance rest and exercise. Okay, so after polymyositis, we'll come to the second topic, which is a short topic, means dermato means skin myositis. So myositis associated with skin diseases. And if we look at the dermatomyositis, it is a disease of the muscle characterized by inflammation and skin rash. So myositis with dermatological manifestation is dermatomyositis. And usually it is again an inflammatory myopathy. Age of onset is usually between 40 and 60 years, but can be seen in young children in 5 to 15 years. Women again are more commonly affected, and polymyositis is similar condition, but symptoms more on the skin manifestations. So they may have other symptoms like polymyositis. They may have dysphagia, muscle weakness, stiffness, soreness, and purple. This is the dermatological manifestation. Especially, you can see the purple violet colored upper eyelid rash. That is helidrop rash are seen around the eyes, and purple red skin, violaceous rash, and there may be pulmonary involvement leading to shortness of breath. Muscles which are usually affected, they may have sudden or gradual, slowly weakness over months, and have a difficulty again in raising arm, rising from sitting position, and climbing the stairs. So rash may appear over the face, knuckles, neck, shoulder, upper chest, and the back. So they have a very typical characteristic rash, that is a purple colored heliotropic rash over the around the eyes, may have knuckles, neck, and the shoulders. I'll show you the diagram later on. So this is a typical violaceous reddish purple heliotropic rash. This is you can see a lady with a rash named after the tendency of plants to grow toward the sun. That is heliotropic rash and is characteristic of dermatomyositis. And you can see the another purple violation plaques. These are the appearance of purple violation plaques on the knees and it may be associated with dermatomyositis. And these are the Gottron papules over the on the hands, and red thickened scaly skin over the knuckles. And this is the heliotrope rash around the eyes. The typical heliotrope rash with the purple violaceous rash over the eyelids, and the eyelid heliotrope, that is a bottom papules on the knuckles, and cat is defining in the dermatomyositis. So dermatomyositis is a myositis with skin manifestation like heliotropic rash, bottom papules, and other violaceous rash over the body. These are the Gottron papules. You can see the violaceo colored inflamed erythema over the knuckles. So these are the Gottron papules. Typical purple colored. If you see these rash, you will not forget, and they are characteristic manifestation of dermatomyositis. Again, you can see the periangle erythema, may be associated with the candida infection, but usually there will be a nail fold maceration, and you will see the periangle erythema. Okay, so differential diagnosis, again, you will make a diagnosis of patient with polymyositis with skin manifestation. That is the most likely case of dermatomyositis. And you will check for muscle inflammation, CPK in alveolar level. You will see the ECG, check for any cardiac conduction defects or other clinical manifestation, and electromyography and muscle MRI and muscle biopsy. So apart from your skin manifestation, same are the investigation as seen in polymyositis. You will go for CPK alveolar level, ECG, and for conduction defect, electromyography, MRI, and muscle biopsy. Okay, treatment, again, you have to go for anti-inflammatory drugs, immunosuppressant like steroid sparing drugs, and corticosteroids are more commonly used in these patients. And if patient needs high dose of steroids, like more than uh, 20 to 30 milligram per day, they need to be tapered off and add on steroid sparing drug like azathioprine or methotrexate, because long-standing steroids can lead to lot of complications. I told you, especially secondary diabetes, Cushing syndrome, hypertension, uh, bone osteopenia, and other manifestation of Cushing syndrome. By immunosuppressant are used, and when muscle strength gets better, the steroids are tapered off. They are usually maintained at physiological dose. Physiological dose means which is a dose around 5 to 7.5 milligram, which does not cause adrenal suppression and does not cause the steroid complications. So it is a physiological dose usually maintained low dose steroids 5 to 7.5 milligram with add-on immune modulating drugs like methotrexate or azathioprine. However, most people, they take prednisone indefinitely on a high dosage and then lead to complication. If condition is associated with the malignancy, underlying tumor, that is as a part of paraneoplastic syndrome, dermatomyositis is usually in elderly patient have a underlying malignancy. So you should be very aware of dermatomyositis in elderly patient with they may have underlying malignancy. So muscle weakness with the rash, which may improve when the tumor is removed. So this is another aspect of treatment. If patient have a malignancy like CA lung, CA ovary, CA renal cell carcinoma, they have myositis with skin manifestation. If you treat their underlying malignancy, and these skin and muscle improvement takes place. So because these patients had underlying malignancy leading to dermatomyositis. So if you treat the underlying malignancy, their associated dermatomyositis is improved. Okay, prognosis in the patient with dermatomyositis. Some patients recover but have symptoms completely disappear, especially in children. But in adults, death may result from severe and prolonged muscle weakness and malnutrition, pneumonia. As I told you, they may have aspiration pneumonias and lung failure because of the interstitial lung disease and pulmonary fibrosis leading to respiratory failure. And major causes of death are usually underlying malignancy and lung diseases. So they may have aspiration pneumonia, may have interstitial lung disease due to pulmonary fibrosis, hypoxemia leading to type 1 to type 2 respiratory failure, and they may die of underlying malignancy, and that is more important to treat as part of dermatomyositis. Okay, possible complications that will be just like polymyositis, dermatomyositis can have acute renal failure, underlying malignancy can get worse, may if not treated can metastasize or local effect and the distant metastasis can take place. Inflammation of the heart and it can lead to pericarditis, myocarditis, conduction defects, and arthritis, arthralgias, and lung condition like pulmonary fibrosis leading to interstitial lung disease with respiratory failure. Differential diagnosis I told you in patient with the polymyositis and add-on dermatological manifestation like heliotrope rash, they have guttural papules, and other manifestation. These are the patient may have myopathy, which is maybe drug induced or toxin induced. Sometimes neuromuscular or endocrine diseases can be a differential diagnosis of dermatomyositis. Infections of the muscles and metabolic storage myopathies and mitochondrial myopathies are other that should be considered as a differential diagnosis. Okay, so anti-synthetase syndrome that is associated with the anti-Jo antibodies and acute onset of polymyositis and dermatomyositis associated with interstitial lung disease, 40 to 60%, and patient usually have a non-erosive arthritis, and the patient may have a history of Raynaud's phenomena. Myositis specific autoantibodies, again we look at the autoantibodies. If we look at the patient with HLA prognosis and steroid, in patient with anti-Jo, patient who have anti-Jo antibody positive, they have a prevalence in 20 to 50% polymyositis. They have anti-synthetase antibodies, HLA-DR3 is positive, and prognosis is moderate, and they usually respond moderately to steroids. While patients who have antibody like SRLP, they have a 5% incidence of polymyositis. They have a severe disease, and DR5 is present, and they have a bad cardiac manifestation and poor prognosis. While patients who have anti-MI2 antibody, they patient have a dermatomyositis with a classical heliotrope rash, polymyositis with esophageal and involvement, and they are the patients who had DR7 and the prognosis is good. So anti-MI2 dermatomyositis with DR7, they have a good prognosis and they respond to steroids. Polymyositis dermatomyositis associated with the malignancy, this is the most common, especially in patients with elderly who are more than 50 years, and associated neoplastic disorders are present. And in the first 2 years, they need follow-up. In polymyositis, the incidence of underlying malignancy 10%, dermatomyositis is 15%, and usually carcinoma of the lung, stomach, ovary, and lymphoma. And routine screening of dermatomyositis should be done in these patients. So thank you very much. Basically, polymyositis is a chronic inflammatory disorders of the muscle leading to involving the limb girdle and shoulder and hip girdle with proximal muscle weakness, and patient may have associated multisystemic involvement, may have Raynaud's phenomena, esophageal mobility disorder, cardiac manifestation, pulmonary manifestations, and these are the patients who should be investigated by raised CPK level, ESR, CRP, and muscle biopsy, and you have is seeing the inflammatory response in muscle biopsy. And these are the patients who are treated with steroids and maintained at a low dose with adding the immunosuppressant or immune modulating drugs. While dermatomyositis is a myositis with cutaneous manifestation like helicobacter rash and other rash around the eyes, around over the knuckles, and these are the patients who can have associated underlying malignancy leading to dermatomyositis. So again, you have to investigate and look for the underlying cause, and these are the patients who can be put on steroids and immune modulating drugs and like methotrexate as a therapy. At the same time, look for the investigate for the underlying malignancy, especially they can have malignancy of the stomach, ovary, other body organs, and these are the patients who have a risk of having aspiration pneumonia, cardiac manifestations, and may have challenges of respiratory. They usually die of aspiration pneumonia and respiratory failure. So thank you very much. Just go for like part of your inflammatory disorder like collagenopathy, like rheumatoid, SLE, scleroderma, polymyositis, dermatomyositis. But usually sometimes they are overlap syndromes, combination of all these collagenopathies. But patients who are elderly usually present with muscle weakness and wasting and especially they say they cannot comb their stand up while sitting on the chair or in the washroom. They once they're commode, they difficulty in standing up. So suspect they may have polymyositis. If polymyositis you suspect if they have skin manifestation, then it is a dermatomyositis. And investigate and put them on steroids and taper off over 6 to 8 weeks to maintain them on a lowest dose steroids and immunosuppressants like azathioprine or other modalities are available for treatment, but these are the simple or cheaper way to treat these patients. But mind for underlying malignancy in patient with dermatomyositis. So thank you very much for your attention, and hope you are staying at home, and because your exam going to be very tough online, and get ready and prepare your topics every day, because these lectures are very important, and it's part of your academic and professional training. So keep your topics ready every day. Thank you very much, and Allah Hafiz.